We're going to do some chest x-rays today. So the first one is a 20-year-old female with chest pain. Does someone want to describe what they see here?
Yes, so the frontal chest radiograph. There's some bilateral mid-zone opacification and some loss of the right cardiac border. And some, is there a lateral x-ray to compare with?
There is, but I'd like you to tell me more about the frontal first.
So loss of the border, the posterior ribs are quite horizontal. So a potential cause could be a pectus deformity.
Mm-hmm.
And it's sort of the anterior ribs curve back in more sharply than expected.
Okay, I'll give you the lateral and you're going to tell me whether that confirms that or not.
I think it does confirm the sternum. You can see angles in.
Cool. All right. So let's go back to that frontal x-ray again. Is there any other signs other than the fact that you've got the right heart border, which is blurred and lost, the heart's shifted across to the left a little bit, and you've got those horizontal posterior ribs, those kind of vertical or steep anterior ribs, creating that kind of 7 kind of shape to them. Is there any other sign on this, on the frontal projection, specific to females?
I think it's prominent. The medial breast margin is more prominent.
Absolutely, yeah. Correct. So it's called the medial breast margin sign. And if you look at a normal radiograph from a female without pectus excavatum, you'll see that you don't really see the medial breast margin like this normally. So when you see it really sharply defined like that and the loss of the heart border, heart shifted across and those ribs looking like that, that's pretty classic of a pectus excavatum. Obviously, what would be the pathology that people might confuse this for?
A right middle lobe consolidation or collapse.
Correct, yeah. So other relevant things you might mention just to add further evidence to the fact that it's pectus excavatum would be mentioning there's no evidence of volume loss in the right hemithorax. You can still see the vessels here in this area. So if it was collapse or consolidation, you might lose the ability to see those pulmonary vessels. You might get some signs of volume loss if it's right middle lobe collapse. All right, awesome. We'll move on to the next case now. I've actually got a picture of that just as a different patient, just to show you that kind of figure 7 kind of shape to the ribs. And if you draw both sides in, it kind of creates a bit of a love heart shape as well. And again, this one's got a bit of that medial breast margin sign as well. Here you can see those much more well-defined than you would in most patients, and that loss of the right heart border and shift of the heart and mediastinum across to the left. All right, next case is a young adult female with a history which is not given. Who wants to have a look at this one?
Yeah, I'll give it a crack.
Okay, go for it.
So it looks like there's a density in the right mid to lower zone that's out in the periphery, basically abutting the pleuro. So it may actually be within the pleural space. And there's a bit of an extension of what looks like an encysted pleural fluid in the horizontal fissure.
Okay.
But the lung fields are otherwise clear. So this could represent either a pulmonary or pleural mass.
Okay, so if it's, you've said encysted pleural fluid in the right horizontal fissure, how might you try and work that out a bit further if that's what it is?
A lateral film would help.
Yeah, okay, a lateral film. Comparison with previous would be useful as well. If this is long-standing, that can be encysted pleural fluid, but often it varies around. Sometimes it comes and goes. Whereas if this has been a constant finding for many years, then perhaps it isn't. What about the morphology on the lateral image? What does that suggest?
So that density is again seen, which if it was just a lateral, it looks like it could be around the hilum, but we already know it is quite peripheral.
Mm-hmm.
Still suspicious for a pleural pathology.
Okay, and if it wasn't encysted pleural fluid and it was a lung, something in the lung itself, What differentials would you think of for that?
Could be some adjacent atelectasis.
Yeah, I'm going to draw your attention to the fact that the density seems to come back towards the hilum, and it's kind of lobulated, well defined but lobulated, this lesion, heading back towards the hilum as well. You can see that kind of well defined lobulated contour heading back towards the hilar vessels. What does that make you think of? Anybody else got some thoughts? No one else willing to chip in? Yeah, so this is a pretty typical appearance for a pulmonary arteriovenous malformation. So it is a little bit tricky given that it's very peripheral and looks like it's almost touching that pleural surface. But having that well-defined lobulated margin, but also having these distended vessels, so an artery and probably a big distended varicosity heading back towards the pulmonary hilum, is pretty classic of an AVM. If this was encysted pleural fluid, on the lateral image, I'd expect it to be following along the horizontal fissure here or following along the oblique fissure and expanding it. But you can see the oblique fissure here is really, really thin. It doesn't seem to be really oriented along the fissure. Okay, so this is a pulmonary AVM. And do you know what kind of underlying causes there are for pulmonary AVMs? You're not sure? Yeah. So they can be spontaneous, but often the patients will have underlying hereditary hemorrhagic telangiectasia. So as soon as you see a pulmonary AVM in the exam kind of situation, usually the next thing out of your mouth would probably be hereditary hemorrhagic telangiectasia. And this is what it looks like on CT. Quite easy on CT, isn't it, to have that? So quite easy on CT. You got that vascular nidus of vessels and the big draining veins heading back towards the pulmonary hilum there. So here's just a little bit on that pulmonary AVM. So if you have a pulmonary AVM, 33% of them with a single AVM will actually have underlying hereditary hemorrhagic telangiectasia, and if you've got multiple pulmonary AVMs, then more than half of them are going to have HHT. Alrighty, but there are multiple other causes as well, and it's worth remembering some of the complications that you might get from having a pulmonary AVM, because it can flick off little clots, so you could get stroke, but also it's going to act as a shunt from the pulmonary circulation into the systemic circulation. So therefore, things that the lung normally filters out, like infections, might also go up to the brain. So you might get cerebral abscesses, for instance. Any questions on pulmonary AVM? All good. We'll move on to the next case. So this one, I'll give the history of a 60-year-old male who's just presenting to the emergency department with shortness of breath. And who wants to have a look at that?
Hello?
Hello, are you going to look at this one?
Yes.
Okay, tell me about it.
So there's a generalised opacity in the left hemithorax, and this would be consistent with a left upper lobe collapse. And there's a Luftsickle sign.
Oh, nice. Yes, there is. So what some of the other signs you can see there?
So there's tracheal shift.
A little bit, yeah.
To the left. To the right, sorry, the patient's right.
Okay. So is that a sign of left upper lobe collapse, do you think?
Veil sign, is that what you call it?
Yeah, there's veiling density, isn't there, across that left hemithorax? Yeah.
Yeah.
Any other features to suggest that that's left upper lobe collapse? You're correct, it is left upper lobe collapse.
Other features.
What about the silhouette? Is there any silhouette sign that tells you that it's a left upper lobe?
So there's loss of the left heart border.
Correct, yeah. And then the other thing is you've spoken about the trachea in terms of volume, But don't forget to talk about the hemidiaphragm and the rib spacing. So you can see here that left hemidiaphragm has come up. It should be lower than the left-hand side. So rather than the mediastinum coming across, that left hemidiaphragm's come up, and you've lost the left heart border because you've got the upper lobe, which collapses anteriorly against the left heart border. You've got this generally increased density from top to bottom, but you've still got the ability to see the vessels in this lower lobe through that collapsed upper lobe. And when it collapses anteriorly, the aortic knuckle is preserved because it's got hyperexpanded left lower lobe kind of sitting next to it. So you get this classic lucency directly next to it called the Lufsickle sign, as you said. What do you think needs to happen for this patient, or what do you think the cause could be?
The cause is most likely an obstructing mass, so they definitely need a CT plus minus bronchoscopy. Yeah.
Good. So when you get a film like this in an exam, you want to volunteer that kind of information yourself. So you want to say, there's a veiling density throughout the left hemithorax with loss of the left heart border, loss of volume with elevation of the left hemidiaphragm. There's no obvious left hilar mass. However, this has the appearance of left upper lobe collapse, and I would recommend a CT to look for an obstructing lesion. What would be another cause, maybe in a younger patient, for a left upper lobe collapse?
Mucus plug-in.
Yeah, so if you've got a patient who's like an asthmatic, then you can plug it off with mucus and get an upper lobe collapse. Like that, it's pretty uncommon though. And then the other thing would be, in an intubated patient, they can get mucus plugging, but it's usually the lower lobes in those kind of settings that block off. Once you've got an upper lobe collapse, it's very, very suspicious that you've got a tumour obstructing it. Alrighty. Any other questions on that one? So that's the hardest of the lobar collapses, the left upper lobe, and it's a pretty classic one that you're going to get in your exams. So next case, 30-year-old male with cough. Someone can tell me about this one for me.
Yep, so looking at this PA chest x-ray, there appears to be bilateral hilar lymphadenopathy and widening of the right paratracheal stripe. And this would be most consistent with Guyland's triad, so concerning therefore for sarcoidosis. I also note looks like there's a poorly defined lesion in the left lower lobe, which, given my concern for sarcoidosis, I'd be concerned about pulmonary manifestation of it.
Okay,
but also I'd be thinking about other primary or metastatic tumours.
Yeah. So when you see this pattern, you're correct. That is hilar lymphadenopathy and mediastinal lymphadenopathy. When you see that, you think of sarcoidosis first. It's pretty uncommon for other things like metastatic disease or lymphoma to cause bilateral hilar and mediastinal lymphadenopathy. Coming back to the hilar regions, what makes you so confident that it's lymph nodes there rather than distended pulmonary vessels?
Yes, I can quite clearly sort of make out all the vessels tracking behind the increased density.
Mm-hmm.
So that's suggesting that's...
Yeah, I don't know. I'd kind of flip that the other way. I think it's quite hard to actually follow the vessels out here. But what we're seeing is these rounded kind of things kind of cutting across the normal angles where we'd expect the vessels to come out. And you look at a normal chest x-ray, you'll see this kind of hilar point, this kind of K-shaped indentation where the upper lobe and the lower lobe vessels divide. And that's kind of filled in here with a rounded opacity on both sides. So loss of the hilar point, this kind of rounded morphology and inability to trace the vessels particularly well through that area is more suggestive of lymph nodes than it is of pulmonary arterial dilatation. Do you know about the chest staging of sarcoidosis?
Not too sure about that.
Not too sure. It's not a particularly useful staging, but so you've got, I think, stage 1. I might have put a slide here actually. Let's have a look. Yeah, here you go. So stage 0 is just normal. Stage 1 is where you've just got hilar and mediastinal nodal enlargement, and that's the majority of patients when they present. And then stage 2 might be outpatient, nodal enlargement plus parenchymal disease, if that area of left lower lobe opacity actually is related to sarcoid, or whether it could be something unrelated to sarcoid. If you've got parenchymal disease only, which is actually an uncommon kind of thing to not have the lymphadenopathy, that's called stage 3. And then when you get fibrosis at the end, that's stage 4. Cool. Any other questions about pulmonary sarcoidosis? I think I've got the CT for this patient here just to confirm that kind of appearance. So see how you would normally have an upper lobe vessel coming up here, lower lobe vessel, and then an indentation between them. And in this case, we've got that rounded lymph node mass sitting in there. We've got, AP window lymph nodes as well. And we've got right paratracheal lymph nodes in over this side, quite extensive. Let's have a look at the lung parenchyma. This patient doesn't have like the classic CT signs of sarcoidosis within the lung. So normally they get these perilymphatic nodules, and the lymphatics follow the bronchovascular structures and the pleura. So you look for these kind of nodules studding the pleura peripherally. There's not a lot of that going on, maybe a little bit of stuff on the pleura just here. You see that? Bit of nodularity along there. So that could be in keeping with sarcoidosis. And then this area is quite non-specific, and it's a little bit atypical for sarcoidosis. It may well be related to sarcoidosis, but this patient may have some other infection going on instead, and just happen to have sarcoidosis in the background. All right, let's move on to the next one. So this is a 45-year-old male in a motor vehicle collision, and he's intubated. Back to the first person, I think, now.
Okay, so it's a mobile supine AP radiograph of the chest. There's an endotracheal tube, which looks well positioned. There is a nasogastric tube, which I can't quite see fully without windowing it out, though.
I'll follow it for you.
The side hole you can see within the esophagus. I think that's probably not in far enough.
Yeah, I agree.
Maybe
stops there.
I can't see if it follows the right main bronchus or not, but at least it's not in far enough, even if it's in the esophagus.
Yeah, okay. What else do you see?
Apart from that, there is 2 chest drains, one on either side, and ECG leads projected over the image. The superior mediastinum looks slightly widened, which may represent a traumatic aortic injury. So it would suggest a CT to have a closer look at that.
Is there a particular side, left or right of the trachea, that looks more unusual to you?
The right side looks wider than usual, the right paratracheal stripe.
Correct, yeah. So the left side doesn't look too bad for, in a patient who's supine, but this right one definitely looks too thick, and it's kind of tracking up here. What do we call that when it tracks up towards the top there?
Not quite sure.
So it's like apical capping. So mediastinal, suggests mediastinal hematoma coming out into the extrapleural space underneath that first rib. All right, so we're concerned about some kind of mediastinal injury. Anything else?
Well, the heart looks more central than normal, but that could just be positional. The patient a bit rotated and slumping to the right.
Yeah, they're a bit rotated, aren't they? You can see that clavicular head there, spinous process. So they're definitely a bit rotated, which may account for that. What else could cause mediastinal shift in a trauma patient?
If there's a pneumothorax.
Mm-hmm. Are there any signs of a pneumothorax on this one?
Right. So yes, there's a supine. So you can have the deep sulcus sign, which it looks like there might be on the left. Yeah,
absolutely. So this looks too lucent down here, doesn't it? You compare that to the other side. It's really lucent down in this left lower zone. We call that the deep sulcus sign. And actually, if you look closely, which is probably difficult on your screens, there is actually a pleural edge that you can kind of see running along here confirming that that is a pneumothorax. So that's the deep sulcus sign of a supine pneumothorax. This is kind of quite a good kind of exam chest x-ray case, because you need to go through and start with lines and tubes, because the ETT is relatively high, the NGT is malpositioned, you've got to comment on rotation because the patient is a little bit rotated, you've got a mediastinal finding to describe, you've got obviously those other lines and tubes, and then you've got the deep sulcus sign. So multiple things that kind of test your ability to go through in a systematic way. Here's the CT just for correlation there. So you can see here's that left-sided pneumothorax, and it's going to sit anterobasally because the patient is supine rather than up towards the apex, and you can see that big deep sulcus coming down here, accounting for that lucency that we see on the chest x-ray. This patient, here's that mediastinal hematoma we can see at the top, particularly on the right-hand side, causing that apical pleural capping as the mediastinal hematoma tracks underneath those ribs. So that was good, well spotted. In fact, this patient's got one of their pneumocaths goes intraparenchymal here, doesn't it? That's no good. Alrighty. One more case. So an 85-year-old male with cough. What do we think of this one?
So we got a frontal chest X-ray, and it's showing quite a large circumferential mass in the right upper zone. There's an area centrally which is suggestive of an air fluid level. So there's some cavitation in that mass and necrosis. And yeah, otherwise everything else looks okay. So I would be quite suspicious for a sort of cavitating pulmonary malignancy or an infection. I guess the clinical history would help. He's got a cough, or whether or not he has a fever, and how acute the onset was.
Yep, perfect. So what would you recommend next?
So he definitely does need a CT scan. Previous X-rays would be helpful as well, just to see how new this is.
Yeah. And are there any features when you look at the lesion itself that help maybe favour tumour with cavitation over infection with cavitation?
It's quite thick-walled.
Yeah, it is.
Something that would make me favour malignancy.
Yeah, that's what a lot of people say, kind of thick-walled, more likely to be a tumour that's undergone necrosis. But you can have a fairly thick wall on infection as well. I think the more useful thing is the lack of surrounding consolidation. So if you've got, like what looks like pneumonia in that area, and then you're forming a cavity with air within it, then you would favour infection. Whereas this one is actually, when you trace it around, it's actually really well defined, this mass, and then you've got thick wall and the fluid level within it. So that would favour tumour for me. But you need to give both differentials. And when you're describing these kind of cases, the examiner might not necessarily tell you that history. So you need to volunteer it. You need to say, if this patient is unwell with fever, then I favour this to represent a pulmonary abscess. However, if this patient has cough, loss of weight, then this may well represent a tumour, bronchogenic carcinoma. What kind of cancer would be most common to cavitate?
So basically, as you said, a bronchogenic carcinoma, I think more likely squamous cell would cavitate.
Absolutely, yeah. So the squamous cell carcinoma is the most classic to cause cavitation. So other than infection and tumour, what other things can cause a lung cavity?
So it can be a non-infectious granuloma.
Yeah, such as
rheumatoid can cause them.
It can. You can get rheumatoid nodules that cavitate. Pretty rare, very, very rare. But what would be more common granulomatous disease that causes cavitation in the lung?
I'm not sure.
Yeah, so granulomatosis with polyangiitis, so what we used to call Wegener's. That's not uncommon for Wegener's to cause pulmonary lesions that actually cavitate. Often it's multiple, often there'll be several lesions rather than a solitary lesion like in this case, but definitely Wegener's is something worth putting in your differential, or granulomatosis with polyangiitis. Then in kids, there's a few other causes. There's actually a mnemonic for this called cavity to help you remember them. So obviously bronchogenic carcinoma, particularly squamous cell. You can get metastases that will cavitate, particularly squamous cell carcinomas from the head and neck metastasizing to the lung. Granulomatosis with polyangiitis, as we've said. A pulmonary infarct could cavitate, again, relatively uncommon. Infection we've mentioned, so an abscess, forming from an area of previous pneumonia, or something like an atypical infection like tuberculosis. In trauma, so if it was a trauma patient, you can form a nematocele that could look quite similar to that, usually fairly thin-walled, maybe some surrounding consolidation, but a history of trauma would be useful. And then in paediatric populations, there's a few other things that are worth considering as well. But the main two are the ones that you said, cancer versus an abscess, and they're the most important ones to diagnose straight away. And then worth thinking about granulomatosis with polyangiitis, particularly if you see multiple cavities. All right, well done. So next case, previous manual labourer, shortness of breath, 70-year-old male.
Hello. So, frontal radiograph. This gentleman has, we've got intact sternotomy wires for a start. And then the main abnormality is he's got multiple opacities bilaterally, but worse on the right. Mm-hmm. They're abutting the diaphragm, and they have the sort of geographic appearance of calcified pleural plaques. So in someone exposed to industrial, someone who's had prior industrial exposure perhaps to asbestos, this would be consistent with asbestosis.
Would you use the term asbestosis?
No, I wouldn't.
Yeah, so asbestos-related calcified pleural plaques, but asbestosis, we want to reserve that term for when we've got fibrotic lung disease due to asbestos exposure. So the lawyers will love it if you call this asbestosis, but we don't want to say that. So there's a lot of people with asbestos-related pleural plaques like this, but a lot less people with the nasty fibrosis that you can get, so the asbestosis. So you mentioned the fact that they look a bit geographic. They're sitting on the diaphragm as well as out here, and maybe here some lining up with the lateral aspect of the chest wall. They look a bit geographic, like continents sitting on a world map. What else about the rim of them tells you that these are likely to be calcified plaques?
The rim is quite prominent and well-defined.
Mm-hmm. Yeah, kind of have these well-defined edges. Do you know what that's referred to as?
Can't remember.
Yeah, it's the holly leaf sign. So like a holly leaf. Yeah. They kind of have that edge, that prominent edge to them. Now, when you get this kind of case in the exam, you want to, obviously you're thinking straight away these are calcified pleural plaques related to prior asbestos exposure. Probably the most important thing for the patient, though, is for you to be looking for any change from a prior film that might suggest there's some pleural thickening which is developing that may be mesothelioma, or if there's any lesion that is actually a lung cancer, because these patients are at increased risk of lung cancer as well from asbestos exposure, as well as often similar patient demographic will have a smoking history as well. So always ask if there's a previous film compared to that to look for any change. And that's about it, I think, with this case. Any questions about asbestos-related pleural plaques? No? All right. There's a holly leaf. Just that really well-defined kind of edge to it is the kind of thing that helps you identify it. All right, I think we're up to the last case now. So a 75-year-old male, let's say that this is just a screening chest x-ray pre-op.
Yep, so looking at a PA chest x-ray, most salient finding is a well-rounded and circumscribed lesion at around the right upper zone of the lung. That's very homogeneous overall, but does have a central section of increased density. So things that I'd be thinking about would be something like pulmonary hematoma, pulmonary mets that have calcifications within, also possible silicosis nodules from that sort of origin.
Okay, very good thoughts. I think it's worth always, whenever you see a pulmonary mass like this, always worth mentioning whether there's any hilar or mediastinal lymphadenopathy, because obviously if there is, it's going to change your differential entirely. And even though you might see some high density suggestive calcification within it, you're still going to be very concerned about lung cancer with nodal mets. But just point out that there is no hilar lymphadenopathy or mediastinal lymphadenopathy, then favour it and say that it's solitary. In this case, I think it's so well defined and there is that suggestion of the calcification within the centre of it that you'd be willing to maybe throw out there that this could be a pulmonary hematoma. What else would you recommend doing?
So I'd probably do a CT as well, because for hematomas to be thinking about possible features of fat within the nodule to confirm it as well.
Yeah, absolutely. First thing would probably be comparing with previous, right? So if you've got the ability to show that this has been stable for very many years, or there's a prior CT, then you don't really need to recommend one. So that would be your first approach. And then, if there's in the absence of any prior imaging, if this is a new finding, then you'd recommend CT. And then on CT, as you said, you're looking for that calcification, which is kind of described as being popcorn-like. So popcorn calcification is pretty typical of a pulmonary hematoma. But you'd be looking for areas within it which are lower density, and you'd be measuring your Hounsfield units on this. See if you can get any negative numbers to suggest that it's got fat. Once you see fat, that's pretty much pathognomonic of a pulmonary hematoma. If you've got a stable lesion over time and fat in it, then you can make the diagnosis of a pulmonary hematoma, which is just a benign tumour of the lung. I think I've got some little facts on that here. As I said there, so presence of fat in a well-circumscribed solitary pulmonary nodule which does not demonstrate significant growth is essentially pathognomonic of a pulmonary hematoma. But unfortunately, you only find fat in about 60% of lesions. You can do thin sections to try and find even very small foci of fat. And calcification is very useful on the chest x-ray. It might be the only thing that you kind of see that helps suggest that it's a hematoma, but lots of other things can calcify. If it's popcorn, then it's very suggestive of a pulmonary hematoma, and they're almost always solitary hematomas.